Welcome everyone. Thank you so much for joining us for today's presentation sponsored by Belmont Village, Chicago, and Broad Street. It's our second in our series, How to Manage Parkinson's So It Doesn't Manage You, meeting the daily care needs of people with PD. We've got Lori, Holland, and Diane Breslow here today to present for us, which we're super excited about. A couple of housekeeping items before we begin. First off, if you've got questions along the way, please feel free to use the chat feature or the questions and answer feature that are on the bottom of the screen. As you're asking questions, we will be, recording them, potentially answering in that chat or Q&A bubble. And then at the end of the presentation, we will have a 10-minute Q&A session. So I will moderate those questions. There's no need for any attendees to come off of mute. And then I'm going to quickly turn things over to Nancy Siegel, who will talk a little bit about the CEU credits and how to get them. Nancy?
Okay. Hi, everybody. All right. After the CEU, you will immediately get an evaluation. And my one request is that that you put your profession and your complete mailing address on it before you return it to me, and make sure I can read your name clearly. You can expect to get the CEUs within a few days. It's not going to be today, but it'll be within a few days. Okay, thank you.
Great, so you'll all get a CEU follow-up email from Nancy. Please complete the different necessary fields to make sure that you get your CE credit. And then just quickly about Belmont Village, Chicagoland, we have 5 amazing locations. Lincoln Park, which is the community I'm with, along with Glenview. Janine is the rep over there, and she is on the video if you scroll on over. Same thing with Susan Cassandra's with our Buffalo Grove community. We've got Erin with our Carroll Stream community on Geneva Road, and then also Shalina, who's not here today, that is with our Oak Park community. And Belmont Village in Chicagoland has 3 levels of care. We've got our true assisted living, a level of care that I'm going to come back to called Circle of Friends, along with a secured memory neighborhood. We really are known for that memory care piece, and that Circle of Friends program is something that's unique to Belmont. It bridges the gap between assisted living and memory setting, and it provides a structured day for our folks with mild cognitive impairment or early stages of memory loss. It's a therapeutic program in nature built with evidence by Beverly Sanborn, who is a gerontologist, a social worker, and it's an award-winning program that we run for our folks that need a little bit of assistance with initiation and routine. Otherwise, in our different communities, we are just really kind of opening up our visitations for our
Janine, do you want to continue on with what she was going to say?
Yes, I will. Hello, everyone. I'm Janine Paterno, the representative from Glenview. And what Lauren is saying is now we follow all IDPH guidelines and have been very strict with our visiting, keeping our residents safe, family safe, employees safe. But due to the guidelines have eased up a bit. We're very thrilled to say we are now having inside visits. Our residents are enjoying and engaging in programming and activities. Our dining rooms are open, and we're getting back to a beautiful social environment, methodically and carefully. We are doing it. So we thank you for this opportunity to partnership with Broad Street, and we're going to turn it over to Diane or Lori.
No, we're gonna first turn it over to Sam Cross, who's the
Sam.
owner.
Okay. Well, Well,
who's
thank
the
you, and
owner
thank you
of
again.
Broad Street. So Sam, take it away.
Sure. Thanks, Nancy. Thanks, Janine, and Lauren. I'm sure she'll be back on soon. I am Sam. I'm the administrator of Broad Street. Just want to say, really appreciate. We're very happy to continue our partnership with Belmont Village. In senior services, it's so important to find partners and work with partners that are high quality and really care about what they do. So we really appreciate the opportunity to work together. A little bit about Broad Street. We provide senior support services to clients in their homes and within facilities. The reason I say senior support services versus home care is that we really employ a solutions-based approach. It's much more highly engaged and much more collaborative with our clients' healthcare network. We really see ourselves as sort of the tail end of a client or a patient's healthcare continuum. So our service is particularly effective with clients that have complex underlying health conditions, specifically Parkinson's and other movement disorders, where we have a comprehensive training program, but also with other conditions and including dementia, Alzheimer's, Lewy body, etc. So how do we do this? We really do it through our care supervisors. They oversee all the care. They come from nursing and physical therapy backgrounds, and they really work collaboratively with each other, as well as the care professionals that are involved with the care. They do this in kind of two ways. One is to provide client-specific training. It's not just about the underlying health condition, it's about the client. The other way that they do that is they're really a bridge to the healthcare network. So they're ensuring that the clinical and therapeutic direction is incorporated into the daily routine. And then they're also providing feedback to the healthcare network so that healthcare providers can really make better decisions by getting more information about how their client and their patient are progressing.
Great.
So today's presentation, we're going to be talking about, it's part of our Parkinson's series, as Lauren alluded to. It's really about education and understanding, but probably more importantly are the practical tools to help people manage symptoms. Last month, we had it with Eric Johnson and Movement Revolution, where we discussed Parkinson's specific exercise. Today, we're going to go into the home, and we're going to talk about how support for daily care needs occurs on a daily basis for people living with Parkinson's. This is going to be presented by Diane Breslow, who's Broad Street's clinical consultant, as well as our very own Lori Holland, who is a senior care professional with Broad Street who provides direct daily support. A little bit about Diane and Lori. For Diane, for those of you who don't know her, has a master's in social work. She's been a career focused largely on people affected by Parkinson's and other movement disorders. She was instrumental in developing a collaborative relationship between Northwestern Medicine's neurology department and Shirley Ryan Ability Lab. So she's a big proponent of multi-disciplinary healthcare support, which is what we definitely espouse. In addition to providing community education and training, Diane is also available as a direct resource to Broad Street as well as Broad Street clients. Lori is a senior care professional at Broad Street. She's a CNA and she's a site champion with Struthers Parkinsons Care Network. The Struthers Parkinsons Care Network is really, it's both an immersion training that Lori has been involved in on how to direct support techniques, but then it's also, there's a feedback loop to continue to develop best practices on how to provide support for this condition. So Diane's going to outline the symptoms, both motor and non-motor, and then Lori's going to provide her direct insight on how to specifically help manage the symptoms on a daily basis. Hopefully these techniques will be valuable for individuals and families living with Parkinson's, as well as to provide insight for the healthcare professionals that work in this field. So with that, I'll hand it over to Diane and Lori. And again, thank you very much, everyone, for joining, and to Belmont Village.
Okay, thank you. So I will start. First of all, I want to reiterate the thanks. I want to thank all of you for participating and being here tonight, and especially thank Lauren, who's done a tremendous job with the outreach and with the organization, and also inviting the whole Belmont Village family to attend this webinar. So thank you to Belmont Village. Thank you to Sam, Nancy, Lori, my co-presenter, and Broad Street. So without further ado, let's move into understanding Parkinson's disease. And Lori and I decided to do kind of a back and forth so that once I give the didactic symptom presentation, Lori can give her illustrations based on her real case examples of people living with Parkinson's disease. So you can move the slide, please. Thank you. Okay, so the overview is we're going to talk about the symptoms. We're going to talk about day-to-day care of those symptoms. We're going to talk about the needs of people living with Parkinson's disease beyond their physical needs. And Lori will provide a lot of helpful hints for the hands-on family care partner or care professional working with the person with Parkinson's. So that's the overview of what we're presenting tonight. So we will move into the cardinal signs of Parkinson's disease. And, you know, I realized that the first point I want to make is Parkinson's disease is a movement disorder. But as Sam very rightly, correctly alluded to, it's a non-movement disease as well, but it gets its diagnosis and its definition based upon motor signs. In addition to those motor signs, it's a very complex, complicated condition that affects almost every level of functioning you can name and you can think of. So I'm going to talk to you first about the 4 cardinal signs. These are the hallmark features of Parkinson's disease. The first one is the tremor, which is probably the most widely recognized of Parkinson's symptoms, even though everyone with Parkinson's disease does not have the tremor. It's something that we do associate with Parkinson's disease. The tremor is a resting tremor. It's not an action tremor. What that means is that the hand tremors or moves like this in the cogwheeling or pill rolling fashion when it's at rest, not when you're lifting something to use it like this. It does not tremor. It tremors at rest. So that's what I mean when I say it improves upon moving the affected limb. It's typically a tremor in the hand, although it can occur in the foot or the leg. Okay. The next one is the rigidity or stiffness that comes with Parkinson's disease. Again, these are movement features. So the rigidity or stiffness is exactly what it says. The muscles are tense, they don't relax, they don't stretch, they could cramp, and there is a stiffness in moving the limbs, the arms, the legs, and we'll talk more about that in the next slide. So you can move the slide, please. Slowness or bradykinesia. I want to say I'm giving you the 4 hallmark features. In order for a movement disorders neurologist to make the diagnosis of Parkinson's disease, the patient has to present with 2 of these 4 hallmark features, but one of the 2 has to be the slowness or the bradykinesia. That is the underpinning, the underlying feature of Parkinson's disease, the slowness or the bradykinesia, plus the tremor, the postural instability, the rigidity. So the slowness really should be number one, and I apologize for that, but the slowness is a decrease in movements. A first sign of Parkinson's disease may be that one arm isn't swinging. So the person could be taking a walk with his or her partner, and the partner might say, hey, move your other arm or move your other leg. Why aren't you? That could be the first telltale sign that there is a general slowness setting in and a decrease in automatic movement. Or the other phrase, the abnormal stillness, that one arm is not swinging and the other one is when walking. The other thing we talk about is the blank facial expression, because the muscles in the face are also slowed down. So the person with Parkinson's disease may not be able to spontaneously grimace or frown or smile or look elated, which doesn't mean they aren't, it just means it's not apparent due to this slowness, okay? And the fourth hallmark feature is the postural instability and gait disturbance. This is clearly the highest risk because the person with Parkinson's disease is walking with a stooped and bent posture, maybe not right in the beginning, but it is can be one of the first signs. And the gait can be little shuffles like this, or it can be actually freezing of gait where the person is unable to initiate the first step. And there can be difficulty in other movements that are related to posture, such as getting up and down from a chair or in and out of bed, and for sure standing upright. So those are our four hallmark features, and those are the ones that are used to make the diagnosis. There's no test, there's no blood test, there's no MRI, fMRI. It is strictly a clinical observational diagnosis over time, where the physician sees these symptoms and feels confident in giving the condition the name of Parkinson's disease. Okay, so I'm going to turn to Lori, and she will give you some examples that involve these hallmark features.
Hi, I just want to say thank you for the opportunity. I hope that we all are able to take something from this and learn a little bit more and help better understand our clients and patients. And so what I wanted to talk about was, how can I help you? And that's what my motivation is with clients. I want to know what I can do to help them, to help me understand, to better assist them so that it's an easier day for them and not a hard one. And what I have noticed is that pills on time is probably the first priority. The pills affect their whole entire day. So if they have a schedule, please stay very close to schedule as possible. If you have any missed medication times, please make sure you make those up as soon as possible. And remember that pills should be taken on an empty stomach. Sometimes we think we can give them a snack and it'll be okay, but according to the neurologist, it's best that pills are taken on an empty stomach. You always want to be patient and understanding. You know, what I do is you can practice the 10 count before asking or repeating questions or statements, because that way you give them the opportunity to process and to speak. There's cueing, and what cueing is just like if they're having problems with walking or they're freezing, I may remind them, let's walk heel to toe, or let's lift our legs like we're marching in a band. And I do it along with them. And I also like to give reminders to help with confusion and forgetfulness. Instead of pointing it out that they forgot it or that, you know, they're confused, I may give a little hint like, oh, I think it's your son, or wasn't it your friend name? What's her name? And she's married to. And with Parkinson's, it's not that they won't remember. Once you give a hint, it comes right to them. So that's another good thing to remember. With the tremors, I can tell that sometimes it can be bothersome and a little bit embarrassing. So what I do is I'll just sit there and hold their hand and sit and talk softly with them, just to help relax that tremor episode, try to de-stress them. I assist as much as needed and never make the client feel embarrassed or ashamed. I implement necessary aids if they have a problem with walking long distances, or if they have a problem with getting in and out of bed. I like to use the rollator or the wheelchair or bed rails or grab bars to make it easier for the client when dealing with those symptoms. And you always want to use the gait belt with Parkinson's. I find that there's no time of prediction. There's times where they're talking and they're just themselves, and in a matter of seconds, they're going down, they're having a melting episode. So you kind of want to always make sure that gait belt is your friend and there to protect the client. And I like to, because their voice is going away, I like to always know the songs that they like so that we can sing together, or that we can maybe read out loud together. Like, I have a client that loves poetry. I'll have him pick a poem, he'll read it, and then I'll read it. And he likes to use emotion. So of course I make it big and broad for him. And we play games and trivia that keeps the mind going, that keeps them feeling like they're, alert. Like, we're in October. What holidays are in October? You can dress up, you can knock on their door and say trick or treat, just things to help them, remember. And then the Struthers Parkinson's Center model of care, what I like about that is they have the word tulips. And what tulips is tulips abbreviation is, tulips is time, T for time, U for understanding, LIPS, we'll say quality of life, increasing awareness, pills on time, and support. And when you think about that model of care, that's all that you want to provide to your client or your patient. And I thought that no act of kindness, no matter how small, is ever wasted. And that is true. You can just make them smile. I love to make my clients smile. I try to make him understand that, even though your face may say something different, I can still see that smile. I'm going to try to fix the sunlight. Okay.
Thank
That's a
you.
little better.
Okay, thank you, Lori. So before I continue with the formal slide, I want to make a couple comments. Based on what Lori said, I want to underline that she talked about the tremor and the stress can increase the tremor. I want to underline and underscore that stress definitely exacerbates the symptoms of Parkinson's disease, any of the symptoms, but the tremor may be the most noticeable. So I want to underline that. Lori also referred to cognition and mental status in a couple of her examples, and to voice. And I just want to say we are going to get to those. But if we don't, or if we run short and don't get into detail on those, you might want to ask about it at the end. The cognition and voice, two major issues that aren't necessarily part of the hallmark features. Okay, so what are some of the other features of Parkinson's disease above and beyond the hallmark features? Autonomic disturbances, and those are things like orthostatic hypotension, which is when blood pressure suddenly drops upon getting up, upon rising from a chair. Urinary disturbances of either extreme. There is a temperature dysregulation where there may be excessive sweating, even if it's not that hot, or an intolerance of heat. Sexual dysfunction is extremely common, as is constipation. Not only constipation as a side effect of some of the Parkinson's meds, but constipation as a symptom of the whole slowness of the disorder. Okay. Thank you. All right, so Lori will talk to you a little bit about how she addresses a couple of these symptoms.
Okay, so for orthostatic hypertension, you can apply compression socks or hose. If they have a really hard time with really going down, I would suggest that you use the compression thigh highs all the way up to the thigh. And they should keep them on usually morning up until about around or about bedtime. Take a daily blood pressure reading so that you can have knowledge of how low they go, or when they go low. You want to also have the wheelchair or a rollator near, and the physical changes like the loss of color in their face, the eyes are bulging, some freezing, falling, or starting to melt down. You do want to elevate their legs. You can give, a massage of the legs and thighs. We found that with the physical therapist, if you put pressure a little bit and like grab the legs and then let them go, it does help. And of course, increase their fluids, usually about 1 liter or more a day, in addition to the other liquids, Gatorade, Propel, water, etc. For the urinary disturbances, I do find that Parkinson patients usually like to take sips of water instead of more drinking of a larger intake. So we do try to monitor at least 1 liter, and then the input and output. You also want to just keep pushing water, even if it's every hour, every so forth. Even if they take a sip, you still want to make sure they get something in, usually from morning up to about dinner time. And then just kind of help them kind of get going to the bathroom. You can go every hour, every 2 hours after they're drinking. And then with the urinary tract infections, which are very common, you kind of just want to, look at what's going on, assess the urine. Does it smell? What does it look like? The color. You want to also communicate that with the doctor, and you can get it at home UTI kit, which I've had a lot of times, just to give you a prediction of what could be going on with that particular information. And as we go on to that, I'm going to go over a little bit so I can get to that part. With sexual dysfunction, it can be a problem, but depending on the age, there's hormone shots, pills, or creams. And constipation is really hard. I had a client that goes like 5 days or longer. What we have instituted was water, 1 liter or more, as well as the dry fruit. So he gets a 3-pack, which is prunes, dates, and mangoes every other day, which has really helped. We do Metamucil, Miralax, different type of things that would help promote that, smooth move tea. And then the decrease in medication, some of the characteristics could change, like irritated or tired. They're unlike their unusual self, increased tremors, hallucinations, or increased hallucinations. Sometimes those are medicine related, so you do want to report those to the doctors as well, because they may need to either go down or go up depending on the characteristics of the changes.
Okay, thank you. So sleep disorders is another area of non-motor symptoms of Parkinson's disease, and sleep disorders come in every way, shape, and form. We think normally if somebody has trouble falling asleep or can't stay asleep, there are many types of sleep disorders that are common to Parkinson's disease. One in particular is REM behavior disorder, where a patient may, in the REM stage of sleep, act out their dreams. So thrash about or get up and attempt to do something that's really happening in the dream. Very common, and in fact has been cited as a early sign or correlated with the future development of Parkinson's disease. It doesn't mean if somebody has REM behavior disorder, they will get Parkinson's disease, but looking back, people who have Parkinson's disease will report years before that they were bothered by REM behavior disorder. Restless leg syndrome is its own neurological condition, but may also be a part of Parkinson's disease. Sleep apnea can be a part of Parkinson's, and excessive daytime sleepiness, which is a major issue in terms of needing to report to the doctor and needing kind of another pair of eyes and ears with you with a patient when he or she goes to the doctor, because somebody may be falling asleep frequently during the day, having excessive daytime sleepiness, which could be the Parkinson's disease, or it could be the fact that their sleep is tremendously disrupted at night for one of these other reasons. And that person could still be driving and unaware that at any moment they could have a sleep episode and not even expect it, which does happen. So the sleep disorders are common. They're normally tested for in a sleep clinic. And there are different treatments for different sleep disorders. So one treatment doesn't fit all. Okay. Okay, sensory problems. These are other non-motor symptoms, and these are in terms of feeling, obviously sensory. And there can be pain with Parkinson's disease. There can be burning, tingling, or numbness. Some people have visual disturbances and will require a visit to an ophthalmologist and treatment for double vision. Impaired color discrimination is a harder one to treat, but it's still something important to recognize. Okay, okay, Lori.
Okay, so some of the physical relief and help that you can provide with Parkinson's, I do find out there's a lot of complaints of back pain, lower back, upper, doesn't matter. It's just back pain, no matter how comfortable you make them sleep. So I kind of consulted with the physical therapist, and you can have them sit in the chair. You can do leg stretches. You know, you just want them to do stretching. There's a hamstring stretch. Heavy legs comes from when they're sitting too long. You can move their legs from side to side. You can squeeze and apply pressure to the calf and thigh muscles. It should not hurt or be painful. It should actually just be just a little pressure just to kind of get the blood flowing, elevate their feet, you know, wrap your hands around their legs. The hamstring stretch, you want to accommodate them according to what they're capable of doing. If it's 10 seconds, 30 seconds, you can do multiple sets, but you don't want to wear them out. And massage is always good. It promotes the blood flow at least once a week, or I would say maybe 3 times out of the month is great. With sleep, you definitely want to pay attention to that. Definitely report it to the doctor, because when we don't get enough sleep, we're crabby. So imagine having Parkinson's and not getting enough sleep. So you're double crabby. So you want to also understand that. And sometimes doctors will prescribe, you know, a sleeping aid like Seroquel or some other medications that would help. And it does give the client or patient great relief. And you just want to always consider those things, like, how can I help you? If they have some information, like it feels like electricity, I like to ask questions. So when I'm asked, I can say what they said it felt like.
I like your graphics on that other slide too. I think they were good illustrations of those.
Thank you.
Exercises. Okay, so some other non-motor symptoms have to do with speech and swallow. Actually, in a way, it's not the hallmark feature, but it is a motor feature in that the swallow mechanism is impaired. The swallow mechanism is slowed down. And because of that, because a person with Parkinson's is not swallowing as frequently as someone without Parkinson's, they are collecting saliva in their mouth. They're stooped usually in their posture, and they may drool.
Yes.
If a Parkinson's patient is drooling, it's not a sign that their body is producing too much saliva. It's a sign that they're not swallowing enough. And Lori's recommendation of frequent sips of water is one of the best for that. But the other swallow issues can occur way down in the swallow physiology, and a lot of our patients will be referred for a swallow test to see where exactly does the swallow issue emanate from, or where is it the most involved. It could be in the mouth, that food, it could be due to chewing, but it could be further down where the food is getting stuck. You might notice this if your loved one or your patient is doing a lot of coughing and throat clearing. That may be because they have a swallow issue. Similarly, they may have a speech issue in that their voice can be very not only slow, but very soft. They can't produce the volume. It can be slurred. It can be fast, it can be mumbled, just like the gait can be all of those things. It can be slow, it can be quick, it can be hard to get out. Think of that and then apply it to the speech, and you would have the analogy to some of the speech issues. So we want to make sure that those are attended to. Here's some of Lori's tips.
Okay, so I think practice can make it easier. With the drooling, I always keep in mind that you want to preserve their dignity and respect. So I think bibs and so forth, I don't use, but depending on the setting, you can accommodate. We use a handkerchief. We use something that's kind of indiscreet. I did take my client for a swallowing exam, and they did find that they did have problems. So the constant coughing when drinking and eating, I try not to talk to them at all so they can focus on the chewing and swallowing. We practice, chin to neck and take a swallow just to help out with that. We add thickener to the liquids, and they were kind of more like, I would say kind of like a mango pulp type of thickener. You want to increase their water intake to decrease the phlegm, because you'll notice they have a lot of phlegm that you literally can pull out of their throat. Don't talk, of course, while they're eating or drinking. Chewing gum. My client, he loves to chew gum. I think that's a good aid for him. It helps him chew, remember to swallow, eat hard candy, the same concept as well. And you can see a speech or language pathologist to evaluate their speech, their voice, the communication, because sometimes the swallowing and the memory, thinking, and function, they can do different type of exercises, their facial exercises, like we smile, we pucker, we open wide. I go, if you want on The Price is Right, show me how you would act, and he'll make those faces. And we use shorter sentences and ask questions with a couple of options, like, you have an orange shirt and a blue shirt today. Which shirt do you feel like you want to wear today? Just give them an option. And he also had a voice magnifier device with a microphone. So it's just like a little lapel pen. And when they talk around family or in an outside setting, you actually can magnify their voice. And sometimes we play a game if they're too low. I always come in like how, the guy said, good morning, Vietnam. I always say it like really loud to him, and I always go, let's see who's the loudest, or, we do big and loud voice exercises. So I just think as much as you can kind of help them do what you can do to make it easier for them, I really think it makes a difference.
Good. Okay, so the cognitive and language difficulties, Lori talked a little bit about this, and I want to emphasize at this point that Parkinson's disease and Alzheimer's disease are two distinct diagnoses. There is maybe not as much now as in the past when these diseases were not understood as well, but there is the fear upon diagnosis of Parkinson's disease that means I will or do also have Alzheimer's disease. That is a myth. Parkinson's disease is not a disease of dementia. It's not a disease of forgetting, but it is a disease of slowed thinking. So if Lori said earlier, if you ask someone a question, you count to 10, wait for them to think it through, wait for them to find the words, wait for them to come up with a response. But it's not that they don't have it, it's that their thinking is slowed, just like other things are slowed. If there are some cognitive difficulties beyond slowness, it does have to do with multitasking. Because of the slowness, it's very hard for somebody with Parkinson's disease to accomplish multiple tasks at the same time. Their mind just doesn't think as quickly. So they're not able to, text, read, eat, answer a phone call, whatever, all at the same time and move from one to the other. And I always say when I talk about this, I've learned a lot I've learned more than I can ever give back from people who have Parkinson's disease. But one thing that I've clearly learned is the concept of slowing down, trying not to be in a hurry and not to do too many things at once and to focus, all that mindfulness stuff, they have to do that. And we have a lot to learn from them about doing that. So that's what I want to say about multitasking. And there is a difficulty with executive function and decision making, which also involves thinking a lot of things through at the same time. So you want to help somebody to partialize a problem or a decision or a choice. Okay. Lori.
And so some of those, like cueing, again, when they're freezing, they're just short, easy, friendly reminders, and they should be said in that manner. So let's take larger steps. March like you're in a band, for instance. Let's pretend we're kicking window panes out of a window. If they're going too fast, you don't want to grab them. You don't want to sound harsh. You just want to say, you know what? Let's stop. Remember heel to toe when walking and slow down. Everything you do should be on the count of 3. So that's like get ready, get set, let's go. So that gives them the time to process it, not just 1, 2, and you're up on before 3. Again, sing a familiar song like the alphabet, Old MacDonald. That helps the brain use a different route to activate and maintain movement. Wait until you feel the chair at the back of your knees and bend your knees while sitting. This makes movement less dependent on the autonomic pilot of the brain. So that also encourages them, oh, I know when something's behind my leg, there's 2 handles, I can reach, I can feel it, I can sit, opposed to just sitting with not feeling anything. And then getting up from a chair, it's really hard. I like to remind them, let's scoot our hips forward to the edge of the chair. Your bottom should be almost at the edge or the bed. Place your feet under you. Remember, you cannot stand up if you don't feel anything under your feet. You must have on shoes, hands on the rest of the arms of the chairs, look over your toes. Now they're in the bending position, and then we'll count to 3 and we'll stand. And we'll also do some stretching or gentle rocking of the knees from side to side before trying to get up from bed. That's to manage their mobility, because I find in the mornings it's terribly difficult. And I think that's when we have to be most understanding, because they don't have their meds, it's really kicked in. And at the same time, some of them like to perform for you as if they were their old selves and not really wanting to accept the Parkinson self. So I try to always think of those cueings and ways to make it where it's not like we're pointing it out, but we're just assisting to make it easier.
Okay. So this is the biggest area of Parkinson's disease that involves social work, which is my profession. And until 10 to 20 years ago, the mood and social emotional component of Parkinson's disease was barely acknowledged. If somebody went to a movement disorder specialist or a neurologist to deal with their slowness, their stiffness, their tremor, you could be pretty sure that the physician would not ask, and have you been depressed? And are you anxious? And are you seeing less people in your life than you saw before? Those were not. Now these questions are as much a part of a visit to a neurologist as the question of stand up and let me see you walk down the hall, pivot, turn, and come back. These questions are the most important, and the reason being that studies are showing that a patient, as well as a patient's partner or the person they're living with or adult child, is emotionally more disturbed and more troubled by these symptoms, these non-motor symptoms, than they are by the motor symptoms. They adapt to the motor symptoms. It may be, it may be embarrassing, it may be difficult, but they have no choice. But these mood disturbances are the most bothersome, not only to the patient, but to the people in the patient's immediate life. And we can go into more detail later, but the key ones are apathy and depression, anxiety, self-consciousness, about the symptoms, about not wanting people to see them, not wanting to be in public, not wanting to be in a restaurant. You can see where that very well leads into a social isolation, a hesitancy to jump into conversations because you don't know how your voice is going to sound. And the psychosis and hallucinations are down there, but if they're going to occur, it's in much advanced Parkinson's disease and or medication induced, which, if that's the case, can be corrected by changing or discontinuing the medication that's causing that. Okay.
I said some of these already, so I'm just going to say just what Diane was saying. It is very important to talk to your client or your patient, know how they're feeling. If they have a friend that passed away, if they're not acting themselves, ask what's wrong, observe, write down, let them tell you, just support them in any way that you can. And most importantly, like she said, with the aids, my client had a really hard time with it. I would always go, I can't wait to get me a rollator. I can't wait to sit in a wheelchair for someone to push me around. And then I would always tell the doctor, please reiterate this to them so that they can get that concept. So I'm not going to take up a lot of time. I just list some, you can see those, but most importantly, pretend like you would like to do that too sometimes. And the hallucinations, don't ever say it's not happening. It makes them angry. Just say, oh, tell me a little bit about it. Or should I make that rabbit go away? You know, just kind of play into it a little bit because it helps them feel better too.
Mm-hmm. Good. Good. So care beyond the physical. Parkinson's disease is very complex and it affects every level of life and every person in the patient's life. And each and everyone living with or affected by Parkinson's disease needs the kind of physical care that Lori and the staff at Broad Street provide, and also need the person providing the physical care to help to provide the other outlets, meaning emotional support, connection, whether it's in an exercise class or a social group, and a community of people. And that's something we talk a lot about in terms of volunteers coming into the home, therapists, exercise teachers, giving caregivers a break and having a respite caregiver come in. So Parkinson's disease care involves every realm of life. Okay.
And I'm just going to say in regards to this, with Parkinson's, we are always taught what the book tells us to do, but you also kind of want to think outside of the book. And that just says like, who's on my team? You know, what are we trying to achieve or implement? When are we going to achieve this goal? Where do we start? How do we manage and maintain the ultimate goal? So although the book sets, I always say the book sets the foundation, it's up to us to build on that foundation. And so that's why I say think outside of the book.
Mm-hmm. Good.
And there's assist and support aids. A lot of them do not need them. But again, I always give a reason why. This grab bar is going to help you not fall. Oh, this Vicks Vapor Rub, your feet, you said they hurt so bad. This will make it feel better. It makes you feel your skin. Let's take a shower. Let's use your shower shoes. They're non-slip. You don't have to worry about falling. That helps ease them. You use Velcro in place of buttons, just things to make it much easier for them, and then give them a good reason why they should use them and how it would benefit them. But the most important, I think, would be a monitor. That way you can see them from a distance. You can talk to them and you can let them know that you may not see me, but I'm watching you. You're safe. You're okay. Give them a massage, check their hearing aids, check everything so that they can still feel like they are socially involved in the community or in the environment.
Yep. So I think what we've kind of pointed out here is the importance of the healthcare team, and someone like Lori in the home, I consider, and Broad Street considers, and hopefully the people in the Parkinson's clinics consider, that the person giving the care is part of that healthcare team and has something to offer to the professionals who are providing the medical care. So often Lori, I think it's been clear that Lori will accompany her patients to the neurology visit so she can both report on some of the signs, symptoms, progress, changes that she's seeing, as well as hear firsthand what may be suggested by the doctor, the therapist, or the social worker. So the whole concept here, and I think Sam said in the beginning, thank you, Sam, that I think one of the things that I have built my career upon over these many, many, many decades is my passion for the multidisciplinary approach to care, but especially the feedback loop and the communication among the whole care team. And care team is a really broad word. It's not just the people in the office at Northwestern, for example, or Rush. It's everyone providing the care, communicating with one another. Okay, so we made this point, providing key information back to healthcare professionals allows them to understand and make better decisions regarding treatment, and it works the other way too. So should we?
So I just wanted to say one thing we have to remember is we are the eyes, we are the ear and the voice for our clients and patients. So whatever is going on, you have to make sure that your observations and your notes are spot on. When you go to the doctor, please make sure you have all those ready. And most importantly, I have a talk with my client and I tell them, because he's really a high achiever. And I says, I know you're going to go to the doctor and you're going to show off. But once he sits down and he asks me what's going on, I have to tell him the good, the bad, and the ugly. So it's not to make you feel any other way, but just to let the doctor know what's going on with you. So I do take all of my bowel movement logs, my histories. You want to make sure whatever they say, you say it as they tell you, not how you think it should have been said, but say what they say. If your ears, watch what they're doing, and then their voice, of course. Make sure all of those are key, eyes, ears, and voice, because they may lose their eyesight, they may lose their voice, and they may not really, hear what's going on. So you have to make sure that you're all three of those and advocate for them. Advocate, advocate, advocate for them.
Mm-hmm.
And
Excellent.
I had one situation. So my client has Parkinson's based exercise class, which he took twice a week. So he says, everyone's about 10 years younger than me. And you know what? I don't think I should keep going. I says, you know what? You're in your 80s. I wish and hope I can, one, get that age, and two, go in there, show those young people up. They're really like astounded. They really admire you. So, he kept going. I informed his neurologist of these observations, and he increased his meds, because what he would do is he was fine throughout the day, but I noticed during exercise, he would start to go down. So he would, just stay right there, start to go down. And then when he came out of exercise, he barely could walk. So I talked to the doctor. They increased just one carbidopa levodopa for that hour before, and everything just ran smoothly. He felt better. He was more confident. So my observations and my ears and my mouth and voice really spoke up to help get him not declining at that time of day, but kind of just staying right where he needed to be.
Absolutely crucial. Very, very, very good. Okay, well, again, thank you to everybody here, and really our clients and families and teachers and those who taught us. Thank you. Thanks, Lauren.
Well,
Yes.
We've got some great questions that I am going to read out to you guys now, because I think we've had such a dynamic conversation, and clearly you both are such a wealth of knowledge on this topic and how to provide the best care and really kind of think about that person-centered care especially. But one of the first questions we have is, do you have any suggestions for communicating with a person with Parkinson's disease whose speech is unintelligible a lot of the time?
So is that for Diane or I? Well,
Go on.
my client does have that issue. And when he talks really low or I can't understand, I go really close to his ear and I go, let's tell a secret. So he'll whisper, I'll whisper. And then I say, I need you to talk a little louder so I can hear you. Or I just start raising my voice really loud. And I go, who talks the loudest? and they'll talk the loudest. And you can use flashcards with, you know, ABCs and so forth, just to promote that loud voice. You want to be loud to make them loud. It does work. And you can do practices as well with voice and so forth.
I'll just say very quickly, big and loud is a patented, trademarked exercise for speech and voice. Some of you may know that. But what Lori's saying about loud, the reason loud works or has the potential of working is in order to speak loudly, somebody has to sit up straight.
Yes.
Number one, and their posture isn't good to begin with. So you're challenging them to sit up straight, to take a deep breath, to open their mouth as wide as they can. And remember, that could be a challenge too. So everything you're asking somebody to do when you say speak loud is involving things that they may not realize. It's their posture, their mouth, and their projection and their breathing. So that's what loud is all about.
Okay.
I hope that helps.
Yeah, I think so. And another great question we got is, if a cognitively intact individual with Parkinson's has severe sleeping issues at night, would a psychotropic medication like Seroquel be prescribed? What any insight into that?
It may. Yes, it may. I mean, I am obviously not a physician, but I've worked around with the physicians, and that may be one of the drugs of choice. It may be melatonin too. I mean, it could be a lot of different things, but once the sleep disorder is diagnosed with more specificity, then the treatment can be applied. But yeah.
And I agree too. I just wanted to say my client was in that scenario. He did try melatonin. According to the neurologist, melatonin works about 2 weeks. You take it, then stop. But now he's on Seroquel. And I will say he sleeps amazingly. And I think just that little half a dose really made a difference in his life, his mood, and everything. So definitely talk to the doctor when it comes to their sleep, because it affects everything.
Right, but be careful that you don't like try something that you already have at home, for example, because there are sleep medications, approved sleep medications that are highly contraindicated in Parkinson's disease. So you want the ones that aren't going to have the psychotic and serious side effects, of which Seroquel is the one that's most widely prescribed.
Yes.
Sure.
Okay.
How do you support autonomy while making sure not to ignore challenges?
How do you support what with
autonomy? So how do we keep our folks with PD independent while also not ignoring their deficits or challenges?
Very good question.
Really good question. I feel like that's a hard one.
I think what I do with my client is I focus on his strengths. The things you know that they're really good at, let them do. The things that you know they're not, you'll say, you know what, I'll do this, you'll do that. So they can kind of feel like, and with buttons, there's all type of mechanisms. You put it on, they can pull it through. But me, I always focus on their strengths, and then I'll take the weaknesses without them even knowing it.
Okay. Yeah, and then also, some good questions here. Just at what point should professional care really be considered in the full trajectory of Parkinson's?
Excellent question.
Yeah.
Do you want to go for that, Lori, or do you want me to say?
You can start and I can go after you.
Okay. Well, it's very hard. And I mean, I think many of us here tonight understand that somebody is going to put that decision off rather than make it too soon. But of course, falls and being at risk are the most serious symptoms or experiences that might be the red flag. And although I don't know that Broad Street, well, let me just back up. Some people like to start slow. So they'll have somebody come in at a certain time of the day. Let's just try it for morning, or let's just try it for accompanying you on walks. So pick something like that. And the reason I hesitated when I said that is Broad Street is really all about the intense involvement like Lori has and the full-time involvement. But I think we understand that that's not for everyone, and people may need to work up to that.
And I was just gonna say, look, if who's ever monitoring, usually their daily living activities, any change definitely falls. And for me, my client, I started out slow. He told me he really didn't want anyone there. And, you know, I told him, I get it. You know what? You've been doing what you do all along. And just think of me as just someone that's going to sit with you, and whatever you need me to do, I'll help you. So our 4 hours went to 6 hours to 8 hours till now. Doesn't want me to go, but I will say you have to just watch their daily living activities, because either they will start with the dressing might be different, or their grooming may not be so upkept. They're very forgetful of, oh, I have to go to the office tonight, when they normally go in the mornings. So sometimes they don't even fall yet. It's just their change in their everyday living activities, which really kind of lets family go, hey, wait a minute, she never did that.
Yeah, and then one last question we have here, kind of a combo question, is can you talk a little bit about some of the newest medications and treatments available, including the relatively new drug Nuplazid, and any comments you have there would be greatly appreciated.
Nuplazid, is that the one that's advertised on TV for the psychosis of Parkinson's disease? I think. I'm not even 100%.
Good question. I don't know. And it's okay if you don't know also, just because, you know.
If that's the one that I think it is, and most of these things, they only work in a small subset of situations. Similarly to deep brain stimulation, you know, for a long time, everybody wanted to know, well, why can't I have deep brain stimulation? It helps with my tremor, or it helps with my slowness. There are so many criteria before one can even be a candidate for something like deep brain stimulation. Similarly with these antipsychotics. So, you know, there aren't a whole lot of new drugs per se, but there are a lot of new delivery methods of the drugs, and that's very helpful. There are some dissolvable, there are some injectable, so it's not always a pill that is swallowed. So I think that's important, the deliverable, the way it's delivered.
Yeah. And I would have to say my client does not take a lot of medications. It's just 2. And for me, I'm not a pill or a medicine person, so I think less is better. A lot of hallucinations are usually medicine related. So, you know, I just think if they can just do other things outside of just depending on those pills and so forth, I'm always an advocate for that. Awesome.
Well, that is all of our questions. And I, you know, gotten a lot of comments on thank you for the great resources and information that you For everyone that's still on the call, I will follow up with a recording of the session along with the slides, because I have several people asking about those. So we'll definitely get those resources to you. And Lori and Diane will both be actually CC'd on that email, so you can reach out with questions specifically if you would like to. Absolutely. And for those of you that have joined us today for a CEU credit, again, keep an eye out for an email from Nancy Siegel. And please be sure to fill out the contact information and your profession on that in order to make sure we can get you that CEU credit. But otherwise, we really appreciate you joining today's one. And Lori and Diane, round of applause.
Thank you. Thank
everyone that you can't see. You did a fabulous job, and we really appreciate you speaking today and sharing your experience.
Thank you for allowing us to. I really
thank you so much. And the questions were fabulous.
Yes.
Yeah, we could talk
great
more
questions.
and more.
Yeah. I know, we could just keep going, right?
Yes. Yes.
Well, wonderful.
Thanks,
thank you
Lauren.
all.
Thank
you so much.
You're welcome.